Thank you again for joining us for our first Sanfilippo Speak webinar of 2025, our fourth overall in this series. We are very excited to bring you this family support webinar to provide our families, our caregivers, therapists, clinicians, and anyone that you would like to bring to the table some helpful insights and discussions around these topics that we hear from families that are pivotal to navigating this life with Sanfilippo. So we're really excited to have a BCBA with us today. Caroline Roesel is in the Austin, Texas area, and she's been practicing for about 10 years. She has worn many hats, including classroom teacher, research assistant, analyst, adjunct professor, and therapist. And Caroline comes to us with some experience serving a child with Sanfilippo type B since 2023, and we are very excited for her to share some of her experience with us today on ABA therapy, insurance, writing goals, and kind of working in this space with Sanfilippo. So I will turn it over to Caroline to give us her presentation today.
Thank you, Cassidy. Hi, everybody. Thanks for that introduction. And yeah, I've been working with this precious little boo-boo you see in the picture since September of 2023. BCBAs that are familiar with the rigmarole of treatment plans, that means I've done a handful at this point in January of 2025. So I want to share about my experience with like writing those treatment plans, presenting it to insurance, and getting approval for coverage. I have not had any issues getting things approved, so I want to share my experience with that and answer a few questions if y'all have come up with any barriers. So thanks, Cassidy. Next slide. Okay, what is ABA? And Caitlin, thank you for chiming in on the chat. You shared that you're seeking an autism diagnosis and you're kind of trying to get into ABA. So what is it? It is understanding human behavior and using behavior change procedures using the scientific method. So we're looking at if we introduce an intervention and then we monitor a specific behavior that we're trying to change, is it working or is it not working? It focuses on applying principles of learning to bring positive changes, so skill acquisition and challenge behavior reduction. Current best practices, individualized treatment that's tailored to each person's unique needs. So instead of a specific program that everyone running through the same program, it is tweaked and adjusted just for an individual learner using these principles of human behavior so they get exactly what they need. It is data-driven. There is a big focus on ethics and including assent. Getting assent is especially important to consider for a case with Sanfilippo because you want to keep that skill of like self-directed behavior and self-guidance for them to initiate with activities for as long as possible. There's a big emphasis on caregiver involvement in all cases, but especially cases with Sanfilippo. With my case, I try to meet with parents about once a week. We don't always hit that goal, but if something's going on, we always make sure that we get that. So, and then there's a generalization of skills across various settings. I go in the home, I go in the grocery store, I'm in the clinic where the RBTs, the direct technicians, are providing the care to make sure that he's not just demonstrating those skills in the clinic setting, it is across settings. Okay, next slide. Collaborating with other service providers, speech pathologists, OTs, doctors, BCBAs can be helpful, especially for people like developmental pediatricians or any doctors trying medications to monitor rates of behaviors. So if a doctor prescribes a medication to work on a specific behavior, we can provide a graph showing when in time that medication was introduced and the rate of behavior before and after that. BCBA can arrange the coordination of care or participate if other people request coordination of care. I just chatted with my client's speech language pathologist. So something that we are coordinating on is using his device for requesting and labeling and things like that, and really tweaking the buttons on the device for like long-term usage. And we've coordinated care in the past as well. So that is really important to all cases, but especially cases where Sanfilippo is involved. Okay, next slide, please, Cassidy. So a typical ABA case is going to have that initial assessment and then recommendation for treatment hours until skills are acquired, and then treatment is titrated and they kind of graduate from care. ABA for clients with Sanfilippo, you're again going to have that initial assessment, and then you're going to modify treatment hours based on the progression of symptoms and then other medical needs. And I'll get a lot more into that when we get into like the treatment plan. I'll get into like the transition section of a treatment plan and like how I worded that. For typical ABA cases, it's a comprehensive focus, so like across domains throughout treatment until you're ready to kind of titrate services. And for a case with Sanfilippo, you're more likely to start with comprehensive treatment, meaning we're teaching across all learning domains. And then again, as symptoms progress, you're going to be shifting the type of treatment to really focus on those essential domains and keep the most essential skills. BCBAs on the webinar who are familiar with Essential for Living, that's the assessment and curriculum that I'm using with this client. So if you are not familiar with that, it's a good idea to check that out. Parent support, as I mentioned, is involved in all ABA cases. But whereas in a typical ABA case, you might have parent support, like teaching specific skills. So like I'm teaching a parent exactly how to get their child to request vocally. With a child with Sanfilippo, you're doing that. And I strongly recommend an emphasis on just the general principles of human behavior. Yes, yeah, thank you, Kara. So what does that mean? BCBAs, you've probably had a case where you have sensed, you've observed that certain principles of human behavior are more influential with this kiddo, this teen or adult for whatever reason. Like let's say you have a case and you know a client is much more sensitive to things like behavior momentum. You're going to teach that parent about behavior momentum, what it is, how it influences their child specifically. You might have also seen cases where like behavior change, you might have had a client where behavior change happen a lot with a specific kid. You're going to teach that to the parent so that they're aware, oh, my kid is like, once a chain gets started, they're like really going to want to keep it going. So that's what I mean about you're going to teach the parent skill acquisition and replacement behaviors, but you're also going to sprinkle in information about specific principles of human behavior that really influence their kiddo. Next slide. More on how ABA can support children with Sanfilippo. It helps prioritize quality of life and dignity. Again, the Essential for Living assessment and curriculum is really helpful for that in the way that it breaks down skills to maintain independence as much as possible. It is sensitive to a progressive decline because we're continually reassessing and shifting and adjusting our treatment plans as needed. It focuses on maintaining as many skills as possible, and the continued use of assessments determines treatment goals over time. So you might find BCBAs that you're reassessing a little bit more often with a case if you have a learner with Sanfilippo syndrome as opposed to a typical case. I reassessed my client every 6 months, certainly, but maybe I would like take a few skills to probe from an assessment and do like a mini assessment in between those two 6-month marks to kind of be my North Compass. Next slide. Some challenges that I've heard of with insurance coverage. Payers and representatives just might not know what Sanfilippo syndrome is. If you've done a medical review and you've been on a call with a representative, they might say something like, okay, can you list all of the diagnoses that this patient has? and you go through them, and you'll have to explain like what Sanfilippo is because they've never heard of it before. This is just a case that's popped up in front of them that day, right? So you're going to become kind of the expert after parent, and explain to them what to expect for Sanfilippo. Insurance might claim that a skill regression alone is a basis for denial. This has never happened to me, and I've never heard of this happening with other Sanfilippo cases when this that I'm like going to get into and explain is used. I've never had, because that this case in particular, I'm on the phone with the insurance rep, and like I've provided so much information about Sanfilippo and my plan for every stage of what happens that it just hasn't come up because I've shown them, hey, this is what the plan is. Another barrier might be if a family changes to a new insurance, you as a clinician are going to have to get accustomed with that payer's like criteria and restrictions if they don't allow certain domains. Next slide. Okay, here we are. This is kind of the meat of the presentation. So before you start putting together your treatment plan and creating goals, you're going to want to go to your payer's website where they list the criteria for exactly what's needed. And if you need to, you can cite this if you're in a medical review, like, oh, well, I wrote this goal a specific way because I see on your website, you have this criteria, like you don't. So the next one says restrictions. You might say, like, I see that you don't allow teaching in the adaptive routines domain unless challenging behavior is demonstrated. And that's actually the case that's happening. In Texas, at least, United Healthcare, for example, does not uh, cover teaching adaptive skills like washing hands, toileting, any adaptive or daily routines, unless challenging behavior is demonstrated when the client is asked to perform those skills. So that would be an important detail for you to know and keep track of in your data. Next slide. So writing the treatment plan, I'm going to go through where in the actual report I have put information, sprinkled in information about Sanfilippo. There are places where you can cite information from empirically validated studies, like from the National Institutes of Health. So these are a few excerpts from a study in NIH about Sanfilippo type B, which is the type that my client has. Behavioral difficulties, hyperactivity, oral perseverative behaviors, tantrums, lack of fear, disobedience, or unresponsiveness, and destructive behavior like property destruction. The other ones are motor restlessness, screaming, sensitivity to touch. So this is all information that you're going to present in your treatment plan or present to the insurance payer if you're in a call. Before they even ask and bring it up, like let them know that you're one of the experts on this because you've looked into this before. We can expect to see, and then list these things: hyperactivity, property destruction, and aggressive behavior. And here's my plan if that pops up. Here's what's worked in the past for challenging behavior. So when this pops up, here's what his ABA care team is going to do to reduce these challenging behaviors. Next slide. In treatment reports, you can clarify what's observed when your behavior change procedures, when your intervention is not in place, because we all know there's holiday breaks. There's, a stomach bug wipes through the clinic and like he's out for a week, your client's out for a week. So what instances like that create is this really nice A-B reversal design. Put a phase change line in your graph. Take note of when that client is out. So if there's ever any question about like, hey, is what you're doing really working? Because skills are going to regress. So how can you tell if your intervention is working? You can refer to your graph and say, this is how I can tell my intervention is working. He was out for a week, and when he came back, challenging behavior was resurging, and then we implemented the intervention again, and challenging behavior declined. Okay. And information from parents about a resurgence in challenging behavior. So Like if they go on an extended vacation during your parent support sessions, ask how did it go? What were some behaviors that popped up, or did behaviors not pop up, and what went well about it, so that you can provide that information if you're in a medical review. Next slide. Payers are going to want to know what are you going to do in the future, knowing the progression of Sanfilippo. So you're going to want to have ready transition criteria for when that day comes. You're going to want to clarify with parents when we at the clinic start to see X, Y, and Z. We're going to start discussing transitioning to like in-home services or something like that. And the insurance reps, if you're on the phone with them, will ask you this information. So have this ready and make sure you've clarified with caregivers ahead of time. If you're using the Essential for Living assessment and curriculum, you can explain to them how you're going to break skills down into steps and then sub-steps as things progress. So the example here is like, if your learner is currently today with their skill level requesting spontaneously, you're going to say, as symptoms of Sanfilippo progress, we're going to prioritize requesting with choices. So you're answering the question before the insurance representative even asks it. You know, because they're going to be thinking like, well, what are you going to do when this skill regresses? But you're already ahead of that question. You're saying, when we see this, this is the plan. Explain how challenging behavior typically arises or resurges as it progresses, and then your plans to address behavior needs. So think back to that National Institutes of Health slide that was showing. You'll be able to list like, yes, we are planning to see an increase in potentially property destruction. We might see changes in his ambulation and walking, and that might lead to some frustration. Here are some behavior change procedures that have worked in the past, and here's what we plan to do if we see these behaviors pop up to maintain his dignity and his comfort and his level of independence. Next slide. So with all of that information, because I kind of just went through that really quickly, I want to actually go through like little excerpts of sections of a treatment plan now. And I want to show you where I've taken this information and put it in the document. Okay, so information related to the symptoms, behavior details related to skill acquisition in Sanfilippo, and then long-term treatment plans like your transition section at the end of your treatment report. Next slide. So we have, this is our basic goal, right? Very basic. There's the goal here. Let's say you have a payer, like I mentioned before, and they won't provide coverage for a specific domain unless challenging behavior is observed when the learner is asked to demonstrate that skill. Here's how I've written that. Client will complete the hand washing routine in the absence of challenging behavior at 80% accuracy. So there's your mastery criteria. You have your baseline there in the middle. And then in red over here under progress, treatment plans have a little section that's titled like progress or relevant notes or something like that. That's where you can add details about behaviors related to Sanfilippo syndrome and the progression and what you're going to do in response to that. So clients' rates of yelling and refusals continue to decrease when the procedure is implemented. The rate of challenging behavior resurged during a holiday break per parent report. So you're citing that whenever your behavior change procedures were not in place, this was the result. And this is what indicates that the treatment is working and continued coverage is warranted. Next slide. In this one, I added an example of how you might take a goal from Essential for Living and broken it down into like a little bit more, broken it down into one of the sub steps. Yes, please ask questions. I'm trying to save about 20 minutes at the end, by the way, for like let's put some cases on the table discussion, or all questions on the table discussion, and I'll do my best at those. Okay. So here under goal, what I added was, client will complete the hand washing routine in the absence of challenging behavior with 2 or fewer prompts. Whereas 6 months ago, they might have been doing that a little bit more independently. This is an example of, as skill level changes, your criteria for mastery is going to change. Okay, next slide. Another section that's commonly found in treatment plans is titled like the biopsychosocial paragraph or the current behavior profile section. This is wordage from my actual treatment plan, and I just wanted to give some examples of how I am discussing like what is to be expected with a client with Sanfilippo. Children with Sanfilippo type B, who are the same age as my client, oftenly reportedly have aggressive behaviors and severe sleep disturbances, like staying awake for several hours. His sleep continues to be stable except for occasional missed naps. Challenging behavior involves mild to moderate yelling. So why did I say that? I said that so the insurance representative knows, untreated, here's what is documented by the National Institutes of Health. Severe sleep disturbances and aggression. Here's what my client is doing. He's only missing naps every once in a while, and his challenging behavior is just moderate yelling and mild aggression about once per week, okay? So I'm pulling from national norms of cases of Sanfilippo and untreated outside of ABA, right, without treatment. So there's kind of my control group. And I'm noting, like, this is what my client's doing, very different rates of challenging behavior. Next slide. Client's ABA team implemented a visual schedule to reduce yelling and aggression that occurred in the spring of 2024. He had a difficult time in transitions, and so I gave him that visual schedule to kind of anchor him and get him through transitions. In August 2024, challenging behaviors with and without the visual schedule were the same. So the BCBA discontinued the visual schedule. It will resume if challenging behaviors increase, assuming all biological factors are accounted for. So why did I say this? I'm saying this because I'm showing the insurance rep, if I don't need a behavior change procedure and he's just as independent without it, I'm glad to fade that away. That's completely fine, but I'll bring it back if I need to as symptoms progress. Next slide. More info for the biopsychosocial or the current behavior profile section. Client's mother reported that his orthopedist recommended beginning wearing some leg braces to reduce gradual tightening of his muscles, which is a symptom of Sanfilippo, the muscle tightening. Client has tolerated the use of braces. He wears a little back brace, and no behavior intervention has been needed for desensitization. He continues to tolerate wearing his brace during ABA sessions. If new challenge behaviors arise, his ABA care team is going to adjust his BIP. So again, this is just saying, as his symptoms continue to progress, we're going to expect that because that's what's expected with Sanfilippo, and we're going to modify the BIP as needed. Okay, next slide. So in the transition section of a treatment plan, which is usually down towards the end, you can list, again, this is an example of answering their question before they ask it. Well, because what they're thinking is, how long is this client going to be able to stay and successfully participate in treatment in that setting? You're going to answer that question before they even ask it. So as client's primary diagnosis of Sanfilippo progresses, his care team is going to determine his level of need and the most appropriate setting. Criteria for moving ABA sessions from in the clinic setting to the in-home include, and then here's where you will list these criteria that you've been over with parents, chat with your clinical director and the owner of the clinic if you need to, but have these lined up and put in your treatment plan so that that information is there. Next slide. So I just wanted to have this slide to review everything I just went over. So again, kind of envision your treatment plan like the actual document in your mind. You've got a little bit sprinkled into the biopsychosocial section. You've got it in the actual goals in that section that talks about relevant notes. You've got information about Sanfilippo and when behavior change procedures are not implemented, like on holidays. And then down in the transition section, you've got that information about what your plan will be if a setting change needs to occur. Next slide. So I hope that gave y'all an idea of how to answer the insurance representative's questions before they ask it, how to thoroughly research symptoms of Sanfilippo and kind of have that information flowing through your mind before you take that call. And I also wanted to add, you know, there might be another barrier that wasn't on the slide per se. BCBAs, there might be a little voice in your head that's telling you, I don't know if I can do this case. This is a really different kind of case. This is really hard. How am I going to handle these symptoms when they pop up? And I hope you saw from the way I was describing my behavior change procedures that these are all just behavior change procedures that we know how to do. We're reassessing what's going on and what we're seeing in front of us, and we're seeing if we need to change that goal mark at all. We're getting baseline for a few different interventions, and then we're choosing the intervention that works best and we're documenting it. This is what we do for all cases, right? So this is not different in that sense. So that's the information that I wanted to share. Now we have some time left for any questions, specifically about insurance and all of that good stuff. Cassidy?
Hey, so we do have one in the chat so far, so please don't be shy. If you have questions, please feel free to put them in the chat. We'll get to them. So Kara asks, about the Essential for a Living program, that we love it. And her specific question is, how can a parent advocate for the use of Essentials for a Living? Are there, in your opinion, any curricula that could be avoided for ABA, for individuals with Sanfilippo?
Um, I think BCBAs need to be well versed in all of the assessments to make the best determination. The reason why I picked this one was based on level of needs strictly. So BCBAs should be well versed in VB-MAP and ABLES and AFLs and Essential for Living, the peak assessment. Thank you, Caitlin. And if you're well versed in all of those assessments and you've read at the beginning of those assessments, like who that assessment or curriculum is for, then that's going to be your North Compass there. And I think when you do a side-by-side of comparison of all of them, you'll see very clearly why Essential for Living is going to give you the clearest roadmap for what to do as symptoms progress. And again, it's going to give you a lot of ammo to speak with insurance companies about so that you have a plan and you're knowledgeable. Okay.
So another question we've got here, is there a difference in how insurance covers or treats in clinic versus in-home therapy sessions? Is there, have you experienced agencies questioning their efficacy?
Um, I've had payers ask, how are you generalizing these skills? And so if I am providing services in a clinic setting, I need to be able to speak to, am I going out into the community or am I providing in-home support for maybe other types of challenging behaviors are happening because there's all different kinds of, well, it's a different setting, right? So different things are going to pop up. So yes, and then I've had it reversed as well. So if I'm providing in-home support, I might have payers ask, how are you getting them ready to go out into other settings and like tolerate a busier setting? Maybe they'll ask about like social skills, how I'm getting them ready with social skills. So yeah, you'll want an answer for that.
Thank you. Um, and then a question that I've heard before is, who on your team should and does have access to that treatment plan?
So any treatment plan documents, that is all medical documents are the property of the caregiver, of the legal guardian. They can have that at any time, and treatment plans are reviewed before they're like actually implemented. So the caregiver, the BCBA, and then RBTs are welcome to look at that if they want to consume all of that information. Typically, RBTs, the direct therapists that do the implementation, stick to like the behavior plans and the list of targets, but certainly they can as well. People like speech pathologists and OTs, they can gain access to that if the caregiver shares it with them directly, or if there is an ROI, or release of information form that's been signed, and coordination of care can take place like between those two professionals, then I can get the speech pathologist treatment plan and they can get my treatment plan and we can review them together.
On that note, what what would your response kind of be to someone who, at the end you talked a little bit about Sanfilippo is a different case for ABA providers and for BCBAs, you kind of have to get a little creative. What would you say to someone who says, "Well, I don't think this is very beneficial. Maybe they just need speech therapy or they need physical therapy and ABA is not the right thing for them."
I would say look at the outcomes when ABA has not been provided. Look at those NIH articles about the challenging behaviors that are expected, and then ask yourself, who handles challenging behaviors? Because children are actually discharged from speech services and from OT services if there is a barrier of too many challenging behaviors, because that professional can't implement their services, they can't do their work if there's too many challenging behaviors, right? So I think that speaks to the importance of coordination of care on a specific case like this. And because of the way the symptoms of Sanfilippo progress, I can't imagine us not being in that arena.
Yeah, I agree. And would you say as you've seen your client progressing and as you've seen Sanfilippo, progress in him, what are your thoughts on the recommendation maybe of service hours? Do you think those go up, they go down, they stay the same as the child ages?
His treatment hours have stayed the same since I have been with him since September of 2023. Um, but that might change depending on symptoms. So how do you measure that, right? Like maybe there's going to be a time when clients are just significantly more tired from their day to day, and it is affecting treatment outcomes. Then you'll want to speak with the caregivers about, do we want to keep the same number of hours, but less driving around in transitions, and we're doing some in-home now? Do we want to reduce hours, but keep them in the same setting? And looking at what would be the most beneficial for that client in the least restrictive environment possible.
Sometimes you hear that it's once you cut back those hours, it's really difficult to get them back. So
Yes.
is that would you say that's a situation where you would put any stipulations in the treatment plan that these hours are to be included, or how would you approach that?
I would only fade hours if I'm ready to fade hours continually. That's a really good question. I wouldn't fade hours if I like need them back later. But if you need them back later, I would say, look at how you're using those hours. Um, if you want to reduce hours, by 10 for this 6 months authorization, but you're going to need them back later, I would say maybe look at that because there's something going awry there.
And we in our August session that sometimes there can be some discrepancies in what insurance wants to pay for at a certain bank of hours, 0 to 10, 10 to 20, 20, and so on and so forth. So what are your thoughts on breaking those up into an in clinic versus in home at the beginning of treatment? Would you rather see clients more in clinic or more at home?
They should be in the least restrictive environment possible. And for most kids, that is in clinic. Absolutely. And you mentioned, how insurance companies decide on like certain number of hours. I've seen, especially with Medicaid, they take into account age and they take into account level of severity, like severity of behaviors to kind of determine those brackets. So again, that's something that you'll want to document through your assessment. So you're getting as much hours as you need.
And we did have a kind of a question, a statement in the chat about trying to get an autism diagnosis to begin ABA therapy. And aside from, we know Medicaid coverage and insurance coverage, it gets a little funky there. Do you serve patients that are not diagnosed with autism?
Um, yes, but insurance will not cover it. So that would
And
be out of pocket. If I
what
just
would
want
you
to add,
recommend? Oh, go ahead, go ahead.
I want to add if families are in that situation where you've been to a diagnosing provider, which is a licensed psychologist, a developmental pediatrician, a neurologist, and you've not gotten an autism diagnosis, you can still find a provider who will provide services, and that provider can give you a super bill at the end of the month to submit to insurance for like your out of pocket that you've been paying. So that's something that can be done.
And that was actually going to be my question is who would you ask? Who do you see if you're already diagnosed with Sanfilippo and maybe you're pursuing that autism diagnosis as a comorbidity? Who do you even ask? Who do you go to for that? To help
Yeah,
it perfectly answer the question.
absolutely. And that's going to vary by state as well. So Austin is in an interesting situation. Like it's actually very challenging to get an autism diagnosis in Austin. And so looking around in your area for those professionals that I listed and trying to find one of them. And also look at your, I'm kind of talking to parents now, look at your insurance plan because it will specify which provider needs to provide the diagnosis. Some providers will like take an SLP, for some Medicaid plans in Texas and can provide a diagnosis, but not other providers. So
Mm,
parents should keep that in mind as well.
that's a great point. Thank you for sharing that clarification. All right, so we have another question. Any tips on how you work on structuring goals, particularly in the clinic setting? Because we know that social engagement is a very important skill to work on.
Oh yeah, like how do I set up teaching social skills?
Mhm.
Sure. So, I mean, we look at the foundation of social skills, which is imitation. But if you look, what do you need to do in order to imitate other people? You need to attend to other people's behaviors. So you're going to have to figure out, where do I start? Does my learner already attend to other people's behaviors? Okay, now I'm going to teach them not only to attend, but like imitate something that peer or that therapist is doing, and it progresses from there. So now, if you can attend to someone else's behavior, you can imitate what they're doing. Can you imitate two things that they're doing in a row? Can you imitate behavior that is on a video that you're watching? And then once you've mastered that, can you attend to another person's behavior long enough to request from them? Right? So the skills just slowly build on top of one another. That's the art that like BCBAs know how to do.
Set up those situations with other clients? Do you bring in peers? How do you structure that?
Both. And with some clients, you'll find they're more comfortable learning initial social skills from the therapist, from the adult. Why? Because adults are predictable. You'll find that generalizing social skills to other kiddos can be a little bit more challenging because other kids are unpredictable. So I have found in my work that there's a comfort level of like practicing something with a predictable adult and then being a little brave and practicing it with a kid because I don't know what that kid is about to do. Yeah, so again, that speaks to like the progression of when you master it with an adult, let's make sure that you can do it with a peer.
Mm. Um, Push in or provide any services at school?
We should be able to do that. Um, BCBAs used to be more able to go into the school setting. Even 7 or 6 years ago, it was much easier. There's been a shift in coverage. I'm finding across payers, and they have really pulled back on that.
Is, is there anything that you you can see that you can point to that helps those payers accept that, or is it just a insurance policy overall, no school?
I'd be interested in other BCBAs on the call and their experience. With my experience, it's been a flat no, absolutely not. So what you're left with is an opportunity to coordinate care with the teachers and with the administrators. Um, and you can do that kind of outside of session time, and that's deeply meaningful. If you want to go that route, you would be working with the principal and the district and seeing what they allow, if they allow professionals to come into the school for coordination of care.
Any questions at the moment in the chat? So are there any last like bullet points or points that you want to touch on to like stress to anyone watching live or the replay?
Um, just emphasizing that a case like this, we as BCBAs still use the skills that we know how to use. It might just be that the mark, the goal is moving a little bit throughout. Um, a condition like Sanfilippo, it's going to progress, and we can do our best to predict what's coming next. But there's going to be a time when it progresses, something happens, there's a new symptom that pops up that we can't foresee, and that's okay. That's okay, because think about when you BCBAs, think about when you get a brand new case and you're figuring out where the baseline is, right? Your baseline has just moved. It's okay that we need to shift the treatment plan continually over time. We're just shifting, we're using our assessments to find that new baseline. Okay, so I don't want anyone to be intimidated by that.
That's a great point, and it's definitely questions that we hear from our community, and really appreciate your insights today. They are so clear, concise, and actionable, and they have been wonderful. So we really appreciate everything that you shared with us. Thank you again, Caroline, and thank you for everyone who joined us today. We'll see you next time.